The core aim of this academic initiative is to learn from experienced teachers, and today's session truly reflects our vision. So it is our privilege to have with us today Dr. Sunil T. Pandya, sir, one of the most respected names in Indian anesthesiology. His immense contribution to obstetric anesthesia, critical care, and anesthesia patient safety has inspired generation of anesthesiologists across the country. We are honored to have him deliver today's lecture on obstetric critical care, contemporary perspectives for an anesthesiologist. We are equally privileged to have an eminent panel of moderators today. Dr. Major M.V. Bhimeshwar sir, Principal, Pinnamani Siddhartha Institute of Medical Sciences, past National President ISA, retired Additional Director Medical Education, retired Principal Government Medical College Eluru, past in charge registrar and controller of examinations, NTR University of Health Sciences. Welcome, sir.
Thank you.
We are equally privileged to have with us Dr. Nori Venkata Venugopal, sir, Head of the Department of Anesthesiology and Critical Care, Swatantra Hospital, Rajahmundry. Dr. Kallepalli Kurmanath Garu, Professor, Gayatri Vidya Parishat Medical College, Visakhapatnam. Welcome, sir.
Thank you. Thank you.
I sincerely thank distinguished past National President Kuchel Babu Garu for joining today's meeting. Dr. Saroj Madam, KL Subramanian Garu, Professor, Super Specialty Hospital, Anantapur. Other delegates for joining this evening. So without further delay, I request our moderators to take over the session.
Thank you, Dr. Praveen. President of ISA Visakhapatnam, Dr. Anuradha. Secretary Praveen. Today's guest topic lecture, Dr. Sunil Pandya, wonderful person, and my co-moderators, Venu and Kurmanath, and past president, Dr. Kuchel Babu. Good evening to all of you and all the delegates who are listening to this. Today is the topic selected for today is about obstetric anesthesia and the critical care, and who better Sunil regarding this obstetric anesthesia. He's an encyclopedia in obstetric anesthesia. It's not an exaggeration or anything. I know Sunil for the last so many years, maybe 30 years plus.
Yes, sir.
And, I have seen him from his Fernandez days. Wonderful speaker that you have selected, Dr. Praveen, and I'm sure all the delegates will be enriched by the experience Dr. Sunil sharing with you. Without wasting much time, I would request Dr. Venu to give a brief CV about Dr. Sunil.
Venu? Sir?
Venu.
Kurna, sir, please.
Good evening, all of you. I'm very much privileged to introduce Dr. Sunil T. Pandya, who is a very well-known obstetrical anesthesiologist and is very popular for the obstetrical critical care. He is a distinguished anesthesiologist and educator and a leader in obstetric anesthesia and critical care. His current positions are: he is a chief anesthesia, perioperative medicine and critical care, AIG Hospital, Gachibowli, Hyderabad, and he is a consultant, Department of Anesthesia, Pain and Obstetric Critical Care, Fernandez Hospital, Hyderabad. And earlier he is still, I think, he is director Prerna Anesthesia Critical Care Services, Hyderabad. And he is national chairman, Anesthesia Patient Safety Association, APSA India, which is a leading national initiative to enhance the patient safety. And his areas of expertise: high-risk obstetric anesthesia, obstetric critical care, perioperative medicine and pain management, patient safety and critical care medicines. His academic and professional highlights: invited faculty, keynote speaker at numerous national and international conferences, author and contribute to many scientific publications in the fields of obstetric anesthesia and critical care, dedicated member and trainer, and passionate about the education and skill development and patient safety. Thank you, sir. You are welcome to this session. And he has got 3 decades of experience in this field. Thank you. And over to Venu.
With this introduction, I request Dr. Sunil Pandya to start his. Over to Sunil, sir.
Yeah, thank you so much, respected moderators. Dr. Bhimeshwar sir is my teacher and my mentor. Dr. Gurunath Garu and Dr. Venugopal and all the dignitaries of ISA Vizag, executives and team from ISA Andhra Pradesh and other part of the country. My slides are visible.
Yes, sir.
Yes, sir. Yes, sir.
So thank you again, Pods and ISA Vizag for having me for this session today. How much time do I have, sir?
Praveen.
Yes, sir. Time only today. Yours is the only topic, sir.
So whenever you feel that I can go on and on, but whenever you feel that we can discuss, I can stop my presentation. We can have more of discussion.
Sir,
So
sure.
Yes, sir.
that was given to me is contemporary perspective for an anesthesiologist in obstetric critical care. Thank you again, Vizag, for giving me this topic, one of my favorite topic, as has been introduced by the moderators. Nil conflict of interest. The photographs and the case series are all from the Institute and Fernandez Hospital have been obtained with permission. So when we discuss about the metal mortality, the commonest causes of metal mortality are sepsis, hemorrhage, and eclampsia. And as we need to prevent she from dying. So basically, I've coined the acronym she because sepsis, hemorrhage, and eclampsia are the commonest preventable causes of maternal death. And if you look at among the three, hemorrhage is the leading cause. Unfortunately, it occurs in otherwise healthy parturients who are normal at conception. In some parts of our country where the maternal mortality rate has come down, like Kerala and southern India, the shift is now getting the commonest cause of maternal mortality, unlike hemorrhage in most of the part of the country, it is shifting towards hypertensive disorders and cardiovascular causes. And unfortunately, in our country, the incidence of anemia is also very high. So every second woman who dies or who has a maternal death is anemic. So one of the preventable causes of maternal death is anemia and hemorrhage, and we all know that these are all totally preventable. And looking at the maternal mortality across our country, if we see Kerala has made a substantial dent, they have come down to MMR of 30 per 1 lakh living births, followed by southern states like Telangana, it's 41, Andhra is about 47, and other states like if you go towards northeast, it is going up, and certain part of the country it's almost 100 plus, so which is very high. So why Kerala made an impact? One of the reasons why Kerala has made an impact is one is it's a small state, but second important thing that has happened is the CRMD, the confidential review of maternal deaths, which they started in 2010, and fortunately, the deaths because of anesthesia are less, but again hemorrhage, hypertension, and sepsis are the leading cause. And as I said, anesthetic causes are relatively less in number even in Kerala as we see in the West. When the metal mortality ratio is coming down in developed states in the country and developed nations, the metal mortality to study the model is little difficult and challenging. So what we need to do is we need to learn from near misses. Because if you look at the pyramid, metal death is the highest of the pyramid, but most of the things that start occurring or where we can make a dent as an anesthesiologist are prevention of complications. And once we recognize complications, if we manage appropriately, we can reduce the mobility and sometimes we can avert a near miss and also a metal mortality. A near miss is something that we have to work upon because for every 1,000 cases that we do or 1,000 women who give birth, there are about 20 near misses, and all these 20 near misses are totally preventable. So if you quantify, at least if you can conquer sepsis, hemorrhage, and hypertension, we can bring down the metal mortality rate in our country to around 30 as Kerala has done it. So the six places where anesthesiologist can make a difference is we have a ability to recognize early because we are, I would say, masters in monitoring the patient, sick patient. Most of the women who are sick, they require ABCs, and we are expert in ABCs. airway, hemorrhage resuscitation, control of blood pressure and hypertension, sepsis, and similarly, when the mother has comorbidities like cardiovascular diseases or thromboembolism, again, we have the expertise in monitoring them closely and plan appropriate safe anesthesiologist. So where the anesthesiologist makes a difference are, as I said, airway monitoring and safe neuraxles by close monitoring of early warning charts, bundled approach in management of hemorrhage and sepsis and hypertension. And of course, now we are gaining the skills of focus and point of care ultrasound. And the 8 interventions that can turn a death into a near miss is responding promptly. And if we are involved, or if the obstetrician involves the anesthesiologist early, we can respond promptly and we can avoid near miss. And of course, we know that by default in obstetrics, neuraxils are safer, about 8 to 10 times safer than general anesthesia. And we know that in hemorrhage, fibrinogen administration early, I'll elaborate more on this when I discuss about hemorrhage, but control of blood pressure, resuscitating a septic shock, or resuscitating a cardiac arrest lady. Or,
7 kg కదా.
can we have others muted, please? Yeah. Most importantly, the thing that every anesthesiologist has to realize that a pregnant woman, because of the physiological changes that happen during pregnancy, they compensate quite well, and they do not have the classic telltale signs of hypotension or hypovolemia unless she crashes. So they appear to be remarkably stable or normal, and they deceive the clinicians very easily. And signs of shocks appear late. Just to give an example, we know that in the cardiovascular system, the systemic vascular resistance is low, is reduced by almost 15 to 20% because of hormonal effect. We all know that. So when the mother has sepsis, the SVR already is low, and just one more septic shock or vasodilatation, they crash. They crash all of a sudden, and they may have hemodynamic collapse. Similarly, we all are familiar that a pregnant woman, they consume more, the oxygen consumption increases, the FRC is reduced, the residual volumes are same, but FRC is reduced, the closing volumes are reduced, and they desaturate very rapidly. So they tolerate hypoxemia very, very badly. Again, the minute ventilation is increased by almost 45%, but without increasing the rate. So tidal volume increases, the minute ventilation increases. So there is respiratory alkalosis. The normal PaCO2 in a pregnant woman is 20 to 32 millimeters of mercury, unlike non-pregnancy where it is 38 to 45 millimeters of mercury. So a PaCO2 of 35 is impending respiratory failure in pregnancy, and PaCO2 of 40 is considered respiratory failure in pregnancy. So to compensate this respiratory alkalosis, the kidneys, they excrete bicarb more. And so the bicarbonate levels are reduced in pregnancy. It's about 18 to 22 in pregnancy. So pregnancy is a mildly acidotic state. And if there is one more insult like hemorrhage causing constricted intravascular volume, or sepsis causing hypotension or hypovolemic shock, they go in metabolic acidosis very, very rapidly because kidneys have maximally compensated already by excreting bicarb. And we know that pregnant women are a clotting machine. They have a tendency to clot more. And so, in a nutshell, if you want me to describe the physiological impact in pregnancy in one sentence, pregnant women, they breathe more, they pump more, and they clot more, and they are a clotting machine. So catching the deterioration before collapse is what is important, and that's what we are meant for. And one of the best ways is to look into the respiratory chart or the modified early obstetric warning chart. And if you look at the top of the chart, the first parameter is respiratory rate. Top of the chart, the first parameter is respiratory rate. And respiratory rate is one thing, or respirations are one thing which are least monitored in most of the units. If you look at the ICU chart or HDU chart, the most of the time the nurses have a tendency to write 18, 18, 18, 20, 20, 20 blindly. They don't check the respiratory rate. And that is one earliest subtle sign which can pick up a deranged physiology, pathophysiology early. So these are the 5 things that are important, and we need to pick them up so that we can avoid. So if you look at the 6 leading cause of perioperative maternal deaths, or where we can make an impact from an anesthesiologist viewpoint, are major obstetric hemorrhage, hypertensive disorders, unrecognized sepsis, cardiac, embolic strokes, anaphylaxis, and anesthesia. This is the data from our obstetric unit at Fernandez Hospital. If you see, the commonest cause of ICU admission is hypertensive disorders, but hemorrhage is 28.2%. And if you look at the commonest cause of maternal hemorrhage are the increasing cesarean section rate and placenta accreta spectrum. When I was doing post graduation in 1990 to 1993, the Miller described the commonest procedure globally performed or worldwide was the ENT, tonsillectomy and adenoidectomy. That was in 1990s. But in 2000s and 2000 currently, the commonest surgical procedure worldwide is cesarean section. And with cesarean section being that common, placenta accreta spectrum is one of the dreadful cause of major hemorrhage. And we all know the postpartum hemorrhage, 4 T's, the tone, the tissue, thrombus, and trauma. Of these 4 T's, we have added another 2 T's. So there are 6 T's that are important. 4 T's are the tissue, tone, trauma, and thrombus. Tone is the most common cause. But fifth T is the shifting to theater early. Shift the patient to theater early, especially if the patient has delivered in the labor room, because delayed shifting of patient to theater itself one of the cause. By the time the patient is shifted, is too late. And sixth T is the team. Organize a multidisciplinary team early. So you need to have a hemorrhage drill or protocol in the unit regularly so that the 6 T's are followed diligently. And we need to make sure that hemorrhage is tackled, because most of the commonest cause of maternal death in mothers with hemorrhage, globally, if you look at the SOAP metrics or the AOA metrics or the CRMD metrics, it is suboptimal resuscitation and suboptimal skills of resuscitation. Inadequate infrastructure. Sometimes the resuscitator is very good, but the infrastructure like blood gas analysis or point of care testing is unavailable. Delayed call for help is again another important cause, and lack of availability of blood. Fernandez Hospital to this date doesn't have a blood bank. 30 years of our practice, because the logistics of having a component blood bank doesn't work out, because the requirement of blood can be 50 to 100 units a day, and next few weeks there will be none. So to set up a blood bank didn't work out. So we developed a MOU, and we developed a wherewithal to network with blood banks nearby, and not a single cause of maternal death because of hemorrhage in Fernandez Hospital. That is again because of massive transfusion protocol, despite not having a blood bank. So that is what we need to develop. Because if you have a massive hemorrhage protocol or massive transfusion protocol, things become very easy. Wide bore venous access, calling for help early, availability or constituting a multidisciplinary team early is very, very important. And we know that crystalloids are the mainstay. Balanced salt solution is what is preferred. Ringer lactate is hypotonic, not recommended. Normal saline is again hypertonic. I won't say hypertonic, but it can cause hypertonic metabolic acidosis. Again, it's not recommended beyond a liter. So balanced salt solution are the crystalloids of choice. No role of colloids. And we need to know that we should not be overzealous in giving fluids, because dilutional coagulopathy itself can cause more deranged coagulopathy, consumption, or worsens the consumption coagulopathy. And early administration of tranexamic acid is vital, very, very important. Early administration of fibrinogen concentrate is of paramount importance, because delayed administration of blood and blood components, especially in massive hemorrhage, is one of the leading cause of maternal death. So, fibrinogen concentrate administration is of paramount importance. And we all know the SHE trial, or the women's trial which came in 2015, established that if tranexamic acid administered within 3 hours of the established bleeding, the hemorrhage can come down. And the same thing was published in New England Journal of Medicine. So we need to have a protocol of tackling placenta accreta spectrum. We need to, sometimes you may have the most competent obstetrician gynecologist and most competent anesthesiologist, but the center may not have adequate infrastructure. So transfer the patient to a higher center where you have interventional radiology, where you have a vascular surgeon, where you have a oncosurgeon who can do inclinal ligation or clamping the aorta. Because in worst scenario, I still remember a case where we had to clamp aorta in a massive hemorrhage following placenta previta. So we need to make sure that patients are transferred early so that we can minimize, because when you have a rupture uterus, patient can bleed massively. This was one of the patient where the patient bled almost close to 12 liters in less than 10 minutes. So patient lost almost twice the blood volume. So to administer or to maintain blood pressure is of paramount importance, and you need to have fluid warmer, you need to have rapid infusion sets. Generally, very few obstetric units have rapid infusion sets. So what we do is, yes, we tie BP cuff to the crystalloid bottle. We have a 20 ml person syringe aspirate every 3-way cock, and we push and aspirate and push. But yes, importantly, you need to have a system wherein you can give massive transfusion, because do not allow HB to fall to less than 5 grams. The transfusion trigger should happen at when the hemoglobin is at 7 grams and above. Because there's one of the patient where hemoglobin fell to 2.6 grams. This is the patient with tight metal.
దయచేసి నా రిక్వెస్ట్ మీ పైన కంప్లైంట్ లెటర్ వెళ్ళేలాగా నన్ను ఫోర్స్ చేయొద్దండి.
Please, can we have the audience? Yeah. So do not allow hemoglobin to fall to a critical level, because it can cause irreversible damage, irreversible shock. And we know that the coagulopathy in pregnancy is a consumptive coagulopathy, and fibrinogen levels fall rapidly. And we need to maintain fibrinogen levels of at least 200 milligrams per deciliter and above, 220 and above. And this is the reason where if the fibrinogen crashes to less than 100, then importantly, they go into irreversible refractory shock. So we need to have fibrinogen concentrates available in all hospitals where the delivery rate is high. Just to give an example, this is the patient. If you see this patient, this was about a couple of years ago. Hemoglobin was undetectable. It was not detected on the blood gas. pH of 6.8, and calcium was fairly okay. And we gave 3 grams of fibrinogen concentrate within and tech guided transfusion therapy. And if you see within a couple of hours or 4 hours, we could get some pH to 7.7, 7.07. But within 8 hours, the pH returned to 7.39. Hemoglobin was almost, it came to about 11 grams. So what I mean to say is, targeted transfusion therapy, if possible, ROTEM guided or tech guided, is what is recommended. But again, thromboelastography is not available in most of the hospitals. So you can go by the ratio 1:1:1 in case of massive transfusion, when the blood loss is massive. So in a nutshell, how we can survive hemorrhage, we have 10 commandment approach, where we need to maintain circulation, and easiest way to maintain circulation is crystalloid resuscitation. But see that you don't administer crystalloid to cause dilution coagulopathy. Raise the trigger when the hemoglobin falls to less than 7, around 7. Calculate MABL, maximum allowable blood loss. Quantification of blood loss is very important, because estimation of blood loss is grossly underestimated. So quantification is of paramount importance. Fluid resuscitation, do not go for excessive resuscitation. Permissive hypotension is what we recommend. Do not allow hemoglobin to fall below 5 grams, which is a critical blood loss, below which the lactate accumulates. Patient can go into irreversible state of shock. And we need to make sure that we have wide bore cannulas, 16 or 14 gauge. Transfusion endpoints, do not, there is no need to give hemoglobin, raise hemoglobin beyond 10 grams. 9 grams is good, 8 to 9 grams is good enough. Macrovascular hemostasis is very important. So macrovascular hemostasis can be achieved by giving early fibrinogen concentrate, because by the time you administer, you bring cryoprecipitate, you thaw them, it takes 25-30 minutes, and you administer 8 to 10 units of cryoprecipitate. It is a long drawn process, minimum 1 hour it will take. And 1 hour, we know that a pregnant uterus receives 25% of cardiac output and almost about 700 ml of blood per minute. And if 5 minutes of atonic PPH, you can the mother can get exsanguinated. So your resuscitation should be of very, very rapid nature. And microvascular hemostasis can be achieved by administering tranexamic acid and fibrinogen concentrate early rather than cryoprecipitate. So the take-home message should be administer fibrinogen concentrate rather than cryoprecipitate if given a choice, especially in massive hemorrhage. And of course, post-resuscitation care in ICU, and this patient also can be under enhanced recovery. And when you are having massive hemorrhage, sometimes you end up with peripartum hysterectomy or interventional radiology procedure. So communication, counseling, consent, and documentation is very, very important. So when you deal with massive hemorrhage, you deal with the patient with a state of shock. And when the parturient is in a state of shock, administration of inhalational agent is a little dicey, because it can also reduce contractility, and it can also reduce SVR and further worsen the shock. So we developed a KFM mixture, ketamine, fentanyl, midazolam mixture, as a part of TIVA with BIS monitoring. And with this KFM mixture, about 5 ml per hour, 200 micrograms of fentanyl, 200 milligram, 100 milligrams of ketamine, and 5 mg of midazolam, 5 to 7 ml per hour, you can maintain BIS of 52, which is good enough. And you can have a stable, more or less stable, and lung protective ventilation, all those things that we see routinely do has to be followed. So you need to have massive transfusion protocol. We need to prevent lethal pentad. We all know about lethal triad. Lethal triad is nothing but hypothermia, coagulopathy, and metabolic acidosis. But when you are giving massive transfusion, the citric toxicity can happen. You can have hypocalcemia, and importantly, you also have with massive transfusion, you give multiple packed cell transfusion, you have hyperkalemia also. So hypothermia, hyperkalemia, hypocalcemia, coagulopathy, acidosis is a vicious circle. We need to prevent the mother going into the vicious circle of triad, quad, and pentad. And so that's the reason that you need to keep monitoring this woman every hourly blood gases so that we can prevent a maternal death because of hemorrhage. And every unit should have a resuscitation tray or a hemorrhage tray which contains large wide bore cannulas, art lines. Putting art line early is helpful. Vacutainers to keep checking the coagulant parameters, the central venous set and central line. Central line is not necessary in massive hemorrhage, but wide bore venous access is mandatory. So, so in a nutshell, when you have a hemorrhage, use blood judiciously, but too much of blood, too little of blood, and too late of blood are eternal perils, and we need to prevent. And post-transfusion ICU care, long-term follow-up, Sheehan syndrome, etc., is very important. So that was in brief about major hemorrhage, and this is that certainly we can prevent it. The second commonest cause is hypertensive disorder spectrum, and we know that this is the commonest cause of ICU admission in our hospital. This is the 2020 audit data from our dashboard, and when we look at the commonest cause of maternal mortality in hypertensive disorders, it is the subarachnoid bleed are the commonest cause, followed by rupture of liver, followed by acute pulmonary edema. And one interesting thing that I found out or I realized when I reviewed the Embrace audit. Embrace is nothing but reducing risk through maternal audits. It's a Why Mothers Eye audit in the UK. And from 1980s and 1990s onwards, the incidence of maternal death because of pulmonary edema in the United Kingdom virtually zero. It's the last 3 decades or 3.5 decades, the mothers dying because of pulmonary edema, because of uncontrolled hypertension, acute LVF is zero. And this has become possible only because of the presence of anesthesiologist in the labor room. So my recommendation is any high risk unit that has more than 6,000 deliveries per annum, it is better to have an anesthesiologist 24/7, and any high risk referral, hypertension, preeclampsia involve anesthesiologist early, because they can control blood pressure early appropriately. Because when the mother is in pulmonary edema, they just need ABCs, and control of blood pressure is what is important. So acute pulmonary edema is one of the preventable mortality. Similarly, hypertensive cardiomyopathy is also, again, something which we need to work on. So when you look at the cause of maternal morbidity or mortality in hypertensive women, again, suboptimal workup. I must tell you that 70% of HELP syndrome are biochemical derangement. 70% of HELP syndrome are biochemical derangement. And most importantly, when I say biochemical derangement, elevated liver enzymes, low platelets, or elevated LDH can be picked up only when we do the workup. If you don't do, we miss this. By the time the patient has bleeding or hematuria, it is too late. It's overt coagulopathy. So suboptimal workup in terms of preeclampsia profile, lack of insight, because okay, I've checked the platelets in the morning, they were fine. But we know that in HELP syndrome or in patient with preeclampsia with severe features, the magnitude of change happens every 4 to 6 hours. So you need to check that, keep in mind that we may have to repeat the parameters every 4 to 6 hours depending on the symptomatology. And again, inappropriate analysis technique, like we were taught when I was doing a post-graduation, any patient who has blood pressure of 210 by 120, GA is the technique of choice. Spinal is contraindicated. But no, spinal anesthesia can be given even in mothers with post-eclampsia, provided GCS is normal and there is no intracranial bleed clinically. And poor control of blood pressure and seizure control in the perioperative period. So many a times we have, as an anesthesiologist, a few of us have a tendency to discontinue magnesium sulfate intraoperatively because it interacts with our neuromuscular blocking agents. It prolongs the action, and we don't want delayed recovery happening. So we discontinue. But we know that discontinued magnesium sulfate intrapartum or post-eclamptic seizure has highest morbidity and mortality. So seizure control prophylaxis has to be continued perioperatively. It's very, very important. And suboptimal airway resource management, because preeclampsia again is difficult airway, edema will be there, and we need to make sure that we have real laryngoscope and everything. Just to give an example, I've just put few cases that we have experienced, little, I would say atypical, I won't say atypical, but little cases that we don't forget. This is a lady who was a sort of a big shot patient, super deluxe room, admitted with hypertension under control. Preeclampsia profile was normal. She was put on labetalol, 100 mg BD, and shifted to ward. Steroids were initiated at fetal lung maturity because she was 34 weeks. 8 p.m. she was reviewed by senior consultant. She advised repeat profile next day because the previous like 7 p.m. profile was normal. At 11 p.m., patient complained severe epigastric pain, tossing in the bed. She was shifted to ICU. IV fentanyl was given, not in labor. CTG was initiated. She was not allowing the fetal monitoring, and profile at this juncture was sent. HB had fallen to 9 grams, platelets 82,000. Like 7 p.m. to 11 p.m., the platelet fall was significant, 2.2 to 82,000. ALTs and ASTs like SGOT, SGPT in thousands, LDH in 2000, creatinine jumped up to 2.3. The point which I want to raise is this is a fulminant presentation of a HELP syndrome or something like APLA crisis. Bilirubin elevated, lipase in 1000, like with acute pancreatitis. So it's like a preeclamptic angina. And within hours, like in front of us, you could see that urine that was normal became hematuric, and then patient developed frank hematuria and overt coagulopathy with multiple petechiae. So within a patient had a fulminant course, and she ended up with abruption, IUD, multi-organ dysfunction syndrome. She required multi-organ supportive care for almost 3 weeks. We had to do long-term dialysis, tracheostomy, and she was in ICU for 22 days, but she recovered completely. The point which I want to convey is a simple patient who was walking and talking, and within 4 to 6 hours, the entire thing changed. And that is what pregnancy is, and that is what we need to be prepared for. This was a near miss. Had we just overlooked that, had we not seen the profile, we won't have realized the magnitude of situation. Another very, very important thing, again, this is a very, very classic blood gases, which I project everywhere or most of the conferences. You see, this patient came with preeclampsia with pulmonary edema. And preeclampsia profile was normal. She was oliguric. So when we did the ABG, pH was 7.01, PCO2 is normal. So there is no respiratory acidosis. PO2 is 113, that is pulmonary edema, and she was in Hudson's mass. So PF ratio is definitely less. But you see the base excess, minus 21. So severe metabolic acidosis. And we stabilized this woman, and like creatinine also was high, and we give spinal, deliver at around 11 p.m. She came at around, if you see the time, 22:05. At 11:30 she has a cesarean section, and next day morning 6:21, like from 10 to 6, within 10 hours, pH returns back to 7.38. PCO2 is normal, PO2 is normal, no base deficit, come back to normal. Again, bicarb also is normal. So she was normalized within 10 hours. So in this patient, the preeclampsia profile was normal, and had we waited for another, I would say, a few more hours, she would have gone into established acute tubular necrosis or acute cortical necrosis, and we would have ended up with problems. So the point which I want to convey is preeclampsia with oliguria, blood gas will help you to guide decision to terminate the pregnancy is what we realize from our experience. And this is again an audit of our cases, full-blown spectrum of preeclampsia, like hypertensive crisis to eclampsia to severe acidosis, press syndrome, pulmonary edema. But we as an anesthesiologist can make a difference because we can control blood pressure better and we can prevent the seizure better by giving magnesium sulfate. So treat systolic blood pressure and diastolic pressure both. We have a tendency to concentrate more on diastolic blood pressure, but do not ignore systolic blood pressure because high systolic uncontrolled blood pressure, the commonest cause of interstitial bleed. This was another patient who ended up with IC bleed, referral case, uncontrolled systolic blood pressure. So preventable morbidity in a parturient, the patient survived. So hypertension is again control of blood pressure, preventing seizures, identifying HELP syndrome, and terminating pregnancy appropriately. The third commonest cause of maternal death, or where as an anesthesiologist we can make an impact, is sepsis. And quite often the sepsis is unrecognized in pregnancy because lack of insight. And because most of the women, they are tachycardic, they have low blood pressure, they are edematous, they have some sort of breathlessness, and all these things, the physiological changes can mask the underlying sepsis. And again, sepsis is one thing where even in the West, the standards are like eight masks, and the maternal deaths are little high because in sepsis. And importantly, as an obstetrician and anesthesiologist, the antibiotic knowledge is relatively poor among the obstetricians, and we don't follow or diligently have the antibiotic policies in the hospital. And delayed transfers are very, very common. Just to give an example, this was a very young lady, most of the obstetric cases, they are less than 30 years, most of them. 26-year-old G3 P2L2 previous section comes in labor, 37 weeks. She has 37 weeks of gestation, she has PROM, 12 hours duration. So the moment the patient has PROM, the high vaginal swab is sent, and patient is on oral antibiotic, there is no fever, TLC is the normal, high vaginal swab sent. PSC is unremarkable. She came on a Sunday morning. Counsel for spinal, plan A was spinal and plan B was general anesthesia. So 29 gauge Whittaker needle was used, uneventful spinal, 10 mg bupivacaine, hyperbaric bupivacaine. We know that hyperbaric bupivacaine is in use currently because of adverse events. Generally, we always add fentanyl 20 micrograms. We give prophylactic phenylephrine 100 micrograms as a protocol to prevent post-spinal hypotension and co-loading with ringal lactate. But this patient needed 400 micrograms of phenylephrine to maintain blood pressure and 30 mg of ephedrine. So generally post-spinal hypotension, when the hypotension is severe, generally we should think beyond spinal hypotension. So first, the immediately thing that comes to us is it a high spinal? So the colleague who was on duty, she checked the level of spinal. It was a D4 level, so there was no high spinal. Patient had a good finger grip, and patient was phonating well, verbalizing well. So there was no high spinal or total spinal. And patient required almost 400 mg of phenylephrine with 30 mg of ephedrine. We got to manage and send the patient to recovery room, but I was not happy. My colleague who was on duty, Dr. Bhimeshwar's student only, Dr. Kausalya was on duty. She called me and you said hypotension and anesthesia, let us activate the algorithm beyond spinal, think beyond spinal. And when we activated, it turned out to be, we got the cultures, some growth was happening, sepsis was confirmed. We changed the antibiotics, we upgraded the antibiotics, we sent the PCT was high, and we took the culture from the placental membrane and also placental cotyledon, and it grew E. coli. We also alerted the neonatologist. They took 10 ml of blood from the cord blood. So instead of bleeding the neonate so that they can prevent anemia in the newborn, they took the sample from the cord blood and all grew E. coli. gram-negative sepsis. So proactively, we activated the sepsis protocol just because the patient required higher doses of vasopressor post-spinal hypotension, and this is what the take-home should be. So this was a near miss. So we need to have a high index of suspicion. Do not allow the patient to go into septic shock. So this patient, we would have just given some more ephedrine, added in the drip, and shifted the patient to the post-operative ward. Should have been okay for some time and should have collapsed a few hours later. So because again they have a delayed presentation. So the Panchamantra, the 5 of sepsis management, measure lactates, send blood cultures, administer antibiotic, fluids 20 ml per kg, not 30 ml. This is the standard adult protocol, non-pregnant cancel, because pregnant prone to pulmonary edema. We generally give 10 ml per kg, measure, do a POCUS, and then give another 10 ml per kg, and that's so on and so forth. But start vasopressors early. Noradrenaline is a vasopressor of choice, followed by vasopressin. And crystalloids, the balanced salt solution, are very important, and source control is very important. So the Panchamantra is measure lactate, blood cultures, antibiotic, fluids, vasopressor, and source control. When I say source control, you need to identify the source. The commonest source in pregnancy is pelvic source, UTI, or chorioamnionitis. Otherwise, it could be cholecystitis, pyelonephritis, appendicitis, or non-obstetric causes. Breast abscess, not to ignore the breast abscess. And we developed a scoring system. Again, this was one of our first fellow, Kausalya. She developed, along with me, we developed a scoring system to identify sepsis early or derangement early. And this is one of the better score, I would say, compared to all the other scores. It has been validated both in public hospital and private hospital. It is known as Saving Mother score. You can just go to the Google, it's available. So when you have a sepsis, the organisms mostly are gram-positive, gram-negative mixed aerobes. So you need to hit hard and hit fast. So you go for carbapenems along with metronidazole, or metronidazole may not be necessary. Hit hard, hit fast, and subsequently you can de-escalate. So the Panchamantra of sepsis is our one bundle. Our one bundle: lactates, cultures, antibiotic, pressors, and fluids. And sixth one is source control. And you need to send appropriate investigations, cultures. Remember, you can take culture, or you need to take culture from the placental membrane and cotyledon if the mother is for section, or if the mother is delivered normally. Make sure that the yield of organism is more in placental bed. That is very important. And send baseline sepsis profile, and source control is very important. Fetal concern, and make sure that the parallel management, glycemic control, PPIs, like proton pump inhibitors, glycemic control, DVT prophylaxis, all these things are also very, very important. So sepsis again is important. So sepsis, hypertension, eclampsia, or hypertension disorders, if you can control these three things, we are able to prevent at least about 70% of mental death, and we can come down to what Kerala has achieved, to around 30 to 35, what MMR to less than 30 to 35. The sixth common, or the other common cause, is cardiac. Again, when we say cardiac, most of the time the cardiac cause is detected during delivery or post-delivery. Most of the time, if the mother has moderate to lesion, they escape the radar of obstetrician and anesthesiologist. And most of the women, they decompensate post-delivery or postpartum. So make sure that when the patient has unexplained hypotension, is it sepsis, is it anaphylaxis, is it cardiogenic, we need to keep all the factors in mind. So cardiac causes are often undetected, and we have seen that most of the rheumatic heart disease or peripartum cardiomyopathy is diagnosed in the delivery period. And they have vague symptoms like the dyspnea on exertion, which is common in pregnancy. Pedal edema is common in pregnancy. But things that are not common are paroxysmal nocturnal dyspnea. If the mother has PND, it is always cardiac origin. If the mother has fourth heart sound, it is always pathological. If the mother has diastolic murmur, it is never physiological. It is always diastolic. But again, the ability for the clinician to identify diastolic murmur currently is decreasing. Even among the cardiologists, it is decreasing because they rely more on echo. Again, I'm fond of interlacing the cases that we have had. This was another good case. A 27-year-old booked early G2 P1 L0 for elective section. PSC was unremarkable, everything was fine. Early onset severe preeclampsia with IUD was there in the previous pregnancy. Otherwise, everything was fine. I only gave combined spinal epidural to this lady, uneventful single pass. Within 3 minutes after giving CACA, they were put in the Foley's catheter, and this was the rhythm that I saw. It's on ventricular bigeminy. And next minute, I could see she had a run of VTAC. So immediately I told the surgeon, just drape and start. I got the amiodarone, I gave the loading dose of amiodarone and got the defibrillator and managed it as a spinal case. It was attributed that this all these changes are because of spinal, but I was sure that this is something we are missing out. And we requested the surgeon to start immediately, gave amiodarone, stabilized the patient in 4 minutes. Subsequently, we managed the patient as cardiac case. We started prophylactic dobutamine, noradrenaline, even before the patient became symptomatic. I reviewed the PAC chart, antenatal card, everything was normal, unremarkable. She came for she had 9 antenatal visits. And subsequently, we delivered a baby with a good Apgar, normal limits. Post-op ECG was sinus tachycardia, chest X-ray was normal, 2D echo. It turned out to be PPCM ejection fraction of 26%. So now 26% ejection fraction, this patient was asymptomatic. How can that be? But yes, she was having subtle tachycardia, like it was around 108, 110, which we overlooked. So persistent or subtle tachycardia, never ignore in pregnancy. So this was a near miss. We could have avoided it had we made little more introspection. So if you look at the commonest cause of cardiac cause of maternal death in our country are tight mitral stenosis, tight aortic stenosis like stenotic heart lesions, peripartum cardiomyopathy, ejection fraction less than 40%, aortic root dilatation more than 4.5 centimeters, pulmonary hypertension due to any cause, either primary or secondary pulmonary hypertension, or and importantly, any coarctation of aorta. So coarctation of aorta is again goes undetected, and you need to make sure that you palpate the lower limb pulses. Never ignore dynamic circulation, because dissection is quite common in pregnancy, especially if they have aortic root dilatation of more than 4.5 centimeters. So the best way from an anesthesiologist perspective to manage cardiac parturient are PAC R square. Maintain preload, maintain afterload, contractility, preserve contractility, maintain stable rhythm, and maintain stable rate. So PACR square. So if whether I want to give spinal, whether I want to give epidural, whether I want to give GA, whether I want to give oxytocin, whether I want to give carbetocin, just remember that what is the effect of oxytocin on PACR square? Oxytocin reduces preload, it reduces afterload, it reduces contractility, it increases rate, and it can cause tachycardia. So carbetocin, same thing with the pronounced effect. So in a cardiac patient, never use carbetocin, because carbetocin half-life is 4 hours, oxytocin half-life is 7 hours. So you need to remember things in mind. Epidural, graded epidural is safe bet, or low dose spinal with in a combined spinal epidural is again a safe bet. So basically, cardiac diseases in pregnancy, you should have a high index of suspicion. Shortness of breath, what is physiological and what is pathological and what is pathognomonic. So PND is pathognomonic, you need to remember that in mind. Murmurs, diastolic murmurs are pathological, you need to remember that in mind. Again, edema, again, what is physiological, what is pathological. So persistent edema, again, even if the mother is lying down, you need to have a high alert. Distant jugulars, this raised JVP, again, you need to have a high alert. So basically, you need to have a multidisciplinary team, and if the mother is having symptoms, then better to transfer to a higher center early. Anaphylaxis, we know the drug of choice is epinephrine, 200 micrograms intravenously or intramuscularly if the patient doesn't have venous access, but again, it's a totally preventable death. And embolism. When we talk about embolism, again, amniotic fluid embolism, air embolism, and pulmonary embolism, all three are preventable and all three can occur. And as I said, commonest causes for anaphylaxis are antibiotics. And again, test dose, giving test dose, we know that it has its own fallacies, but make sure that evil is not the drug of choice. But adrenaline, yes. Hydrocortisone again doesn't act immediately, but adrenaline is a drug of choice. Early intubation, because we know that sometimes angioedema can make intubation difficult. And we don't, especially we have had few cases patients who reported allergic to local anesthetic, but again, we did a protocolized management and there were no adverse effects. Amniotic fluid embolism, 80% of mothers with amniotic fluid embolism can survive. And we have had 5 cases in last 30 years. 1 died, 4 survived. 80% survival rate. This was another patient whom we got in 2003, young patient, primary gravida with amniotic fluid embolism. We had to sacrifice the uterus, but the couple went home smilingly on the 10th post-op day. She went into severe ARDS. The bottom line is they have a triad of cardiovascular collapse, respiratory hypoxemia, and sometimes you have fulminant coagulopathy also. Or rather, fulminant coagulopathy is the hallmark of embolism. One thing that will differentiate between pulmonary embolism and amniotic fluid embolism is both have cardiovascular collapse, both have acute hypoxemia, but pulmonary embolism doesn't have coagulopathy, whereas amniotic fluid embolism can have fulminant coagulopathy. And when I say fulminant coagulopathy, they need blood in the magnitude of almost 70-80 units in less than 12 hours. So that is the magnitude of hemorrhage that they have. And we need to make sure that you need to have the wherewithal of supporting circulation. Very, very aggressive resuscitation is needed to prevent a patient with amniotic fluid embolism dying. And lastly, the anesthetic cause of maternal death. Again, as I said, airway related issues are the commonest cause of maternal death. If you look at the incidence of difficult airway in pregnancy, the incidence of difficult airway is 10 times more than non-pregnancy. In non-pregnant or surgical population, it is 1 in 2,500, whereas in pregnancy is 1 in 250. And if you look at a pregnant patient with preeclampsia, it is 1 in 50. Pregnant patient with eclampsia is 1 in 10. So every 10th woman with eclampsia is going to be difficult intubation because they may have coagulopathy, they may have sublingual hematomas, they may have buccal hematomas. And if you have to do ICU intubation, it is 1 in 8. Every 8th ICU intubation in a pregnant woman is going to be difficult. So we need to make sure that we have the wherewithal to tackle these complications. And peripartum or perioperative death, because anesthesia can be contributing cause, but any of this cause anesthesia can contribute, but per se anesthetic cause fortunately is coming down. And general anesthesia causes have death as a cause of death have come down because we have switched to regional anesthesia. So airway mishaps, delayed recognition of misplaced endotracheal tube, and aspiration are the 3 commonest cause. And if you see the failed intubation, 31% aspiration, 27% of staff incompetency was there, equipment failure was there, and 6% of high spinals could not be intubated. So anesthetic causes of death are rare, but again, all are preventable. And if you look at that, just to share our data, this was old presentation, but we have had more than 1.8 lakh obstetric anesthetic procedures done at Fernandez Hospital as a team. We have had 3 on-table cardiac arrest because of hemorrhage, because of hyperkalemic cardiac arrest. All survived, not a single death. But more importantly, the point which I want to convey is all these things could have ended with the maternal mortality. So we have had 12 perimortem cesarean deliveries, and this is what the protocol that the AOA task force gave is from this data. One was the mitral stenosis patient with mitral cardiac arrest. ROSC achieved post ACLS, and we had to do emergency percutaneous balloon mitral valvulotomy. She survived. Antepartum MC, acute pulmonary edema, ROSC achieved, she survived. So similarly, many patients, I would say 58% of the women, they survived. 58% of women survived. And the neonatal survival rate was almost 50%. So again, this is I think the largest data of perimortem delivery from a single center in the country last 30 years. The survival rate is good. So you need to have the protocol of aggressive management of multi-organ support and post-resuscitation care. Again, anesthetic complications, if you look at the cause of anesthetic, this is again from the CRMD of Kerala, beautifully analyzed the cause of death because of anesthesia. And if you see the 16 maternal deaths that were reported because of anesthesia, the first patient was tubal ligation. Again, tubal ligation was done under general anesthesia with a mask. We know that postpartum tubal ligation, the risk of aspiration persists till six weeks of puerperium period lasts for 6 to 8 weeks. And this patient developed aspirated under anesthesia, become hypoxic, and she could not be resuscitated. Second case was cesarean section of the spinal. They gave instead of saxamethonium, they gave midazolam. Oh, sorry. The medication was after delivery of the baby, instead of midazolam, succinylcholine was given as a sedation, and they could not, they didn't realize that succinylcholine was given, and until the mother desaturated. Again, totally preventable. The vials of succinylcholine and midazolam were lookalikes. Again, LSCS and the spinal suspected amniotic fluid embolism, best care was given, but patient succumbed. So what I mean to say is amniotic fluid embolism requires aggressive approach, massive resuscitation, the best of airway management skills, the best of multi-organ supportive skills, the best of coagulopathic management. Again, this was a high spinal arrested before delivery. This patient developed refractory hypotension, and patient had and subsequently she was detected to have peripartum cardiomyopathy. They suspected it is PPCM. So post-spinal hypotension, think beyond spinal causes. As I said, if the spinal causes of hypotension, there is no high spinal, think beyond spinal. Because many a times we give spinal, patient develops hypotension, we think it is because of spinal. But back of your mind, have differential. Is it sepsis? Is it cardiac? Am I missing something? Is it drug-related issue? Unless you have an algorithm, you miss out the causes. Again, in small cases, DNC, ERPC, GA was given hypoxic respiratory arrest, resuscitated, but patient sepsis. She was given ECMO also. This is in Kerala, but no, it didn't help. Again, LSA syndromic patient, difficult intubation, arrested post extubation. So the point here is when you have difficult intubation, extubation has to be planned. Extubation is elective; it is never an emergency, and patient dying at the time of extubation. The eighth case was LSCS under some medication, inhaled tranexamic acid was given. We know that tranexamic acid is again notorious. From the time tranexamic acid came as a part of obstetric hemorrhage protocol, the lookalikes incidents have increased. There are at least about 78 cases in the case report. So, as I said, airway, always make sure that you have plan A, plan B. Plan the failed intubation pathway before you induce, and decide in advance the condition under which you will wake the mother or proceed. So airway management plan has to be very, very clear. And again, have second generation laryngeal mask airway with you. Never ever start a case without LMS, because we know that even sometimes Malampati grade 1 can become difficult. I still remember last 30 years or so, we have had at least about 7 cases where LMA has helped in every case. Every 7 cases, LMA was the rescue, and we could manage the entire case with LMA. So now we have IDA guidelines 2025. In fact, I have contributed to the IDA guidelines. The physiological aspects of difficult airway have come because of our center's initiation. And of course, Pankaj Kundra sir also thought about it, but it was not a part of guidelines. So physiological difficult airway guideline, probably you can, our center can take the credit. So again, never morbid obesity patient. Again, as an anesthesiologist, you know that you need to have a ramp. This ramp is very important. This ramp, commercial ramps, they cost about 75,000, but we got this ramp from a sofa maker. It's just a firm foam, and with this, you can this costs just 4,000 rupees. So we know that importance of ramp in a pregnant patient, and importance of HFNO in pregnancy. As I said, intubation can be emergency because of emergency nature of cesarean section, but extubation is always elective. Plan your extubation. Extubation is never a emergency procedure. And post-op airway catastrophes are preventable, and you need to plan all your extubation. So we cannot eliminate difficult obstetric airway, but definitely we can eliminate inadequacies in training and have a video laryngoscope as a primary choice. Obesity is again something which is a senior consultant led or experienced consultant led delivery or cesarean section, because we know that sometimes the depth of the space will be beyond 8 centimeters, and you need to have extra long epidural needles, and sometimes you may have extensive panels in the lower segment, And there have been instances where we have given NIVs in obese parturient during pregnancy, because even after level of D4, sometimes they develop breathlessness. So we need to have NIVs. This was a patient, you can see, despite NIV, she was ETCO2 was around 61 millimeters of mercury. So you can make your GS safe, you can make your regional safe, you can minimize medication errors, you can minimize high spinals, total spinals, and you can minimize spinal cord injuries because of if you can identify the space correctly. Use adrenaline early if it is a high spinal, and activate intraoperative hypotension algorithm if the mother has protracted hypotension. So just to give an algorithm, what we follow is when you have hypotension following spinal, commonest cause anesthetic, high spinal, total spinal, subdural drugs, which we can identify very easily. The surgical causes intraoperative hypertension, you bleeding from uterus, bleeding from liver if it's a HELP syndrome, or it could be aneurysmal bleeds or splenic artery rupture. We know all these things can happen. Or think about patient pathology. Is it sepsis, occult sepsis? Is it occult cardiac disease? Or is it a drug interaction, spinal with labetalol, spinal hypertension with nifedipine has just been given as a part of preeclampsia medication, and it is exaggerated, or oxytocic with drug interaction has happened. So, or the patient has had an embolism, amyloid embolism, especially refractory shock. Sometimes, yes, miscellaneous things can happen. Spontaneous pneumothorax have been known, and especially if you are trying with a low approach central venous cannulation, you may end up with pneumothorax also. So you just have to think that all the possible causes of perioperative intraoperative hypertension. But one cause that was unique in our case, I recall this patient. It was me who gave combined spinal epidural to this lady. Otherwise, fit AS, a grade 2 lady, no other comorbidities. The moment I gave CACA, turned her supine and gave oxygen and put a wedge, she developed blood pressure, fell to 40 and intense bradycardia. And she, after that, I can't breathe, I can't, she became momentary, she lost consciousness. Immediately, adrenaline was there on the table. We keep adrenaline on the anesthesia workstation. We just pushed 500 micrograms of adrenaline, or rather, I would say the entire ampule. And later on, she remained lock stable. She reached, it was not high spinal. We ruled out cardiac causes, we ruled out sepsis causes, we ruled out embolism. Nothing was there. What else could have been there? And this patient told, "Sir, आपने तो मुझे यमराज का दर्शन करा दिए." She almost saw Yamraj in front of her. And when we looked at the antenatal record, she was having large varicose veins, which we ignored, which we undermined, which we were not known at the time of PSC. So the moment we gave spinal, the entire blood volume went into the lower capacitance of these vessels increased, and the entire blood volume went into the lower limbs. So the point which I want to emphasize is there are rare causes which we can do not ignore anything in pregnancy in obstetrics, because sometimes you have these rare causes which are there. So what the patient needed was just a leg up tilt, and subsequently we put a crib bandage, anti-diabetes stockings, and she was all right. So the 6 places where anesthesia can contribute to the maternal mortality is preoperative assessment. So you assess the patient properly, assess the area properly, make sure that you have a plan A, plan B, and LM is ready, and make sure that you don't minimize high spinals, total spinals, subdurals, and last, and make sure that the maintenance drugs of anesthesia are safe, magnesium sulfate, and all those things are taken care of. Extubation should be planned, should never be hasty in extubating the patient, and follow the patient post-operatively, because postpartum eclampsia, postpartum HELP syndrome, postpartum preeclampsia, postpartum collapse can occur. So this patient should be on the radar for several times. So 3 habits as an anesthesiologist which can help us is: do not assist, be the leader, because you have the skills to resuscitate the woman effectively, to manage ABCs effectively, better than any of the clinicians in the perioperative period. So be a lead, don't assist. Of course, you can, when you lead, you need to have a characteristic of a leader so that you can take the herd with you rather than having 6 opinions among 6 people. We should not. You should have effective leadership quality. Preempt the silent killers. So as I said, in hemorrhage, ionized calcium is very important. Warming is very important, and distrust normal blood pressure is very, very important. So a normal blood pressure, normal pulse rate in a woman doesn't mean that everything is hunky dory. So as I said, the women, they have extensive physiological reserve, and the ones they start decompensating, they crash. They crash. So you need to have a backup of obstetric critical care. So as an anesthesiologist, as a perioperative physician, or as an obstetric intensivist, I would say, our idea is to give best to the both the lives. And this is one of the articles that we wrote in IJCCM. And we need to have multi-organ supportive therapy. There is another article that we contributed in IJCCM. But as I said, when we have to give best to both lives, we need to take care of the fetus, and the fetus can get demised if we don't address maternal hypotension, if we don't address maternal hypoxemia, and if we don't address maternal hemorrhage or anemia. So prevention of hypotension, prevention of hypoxemia, prolonged hypotension, hemorrhage, untreated hemorrhage, all can lead to fetal demise. So as an anesthesiologist, as an intensivist, my aim is to give best to both the lives, live baby and live mother. And we need to know the transplacental hemodynamics, how much pressure I have to maintain, because placenta doesn't have auto regulation, and we need to maintain maternal PO2 of at least 75 millimeters of mercury and above, and be well versed with the focus skills, because we know that focus is going to be the future and we should not shy away. And if the need arises, go to the best of critical care management. We have had a series of ECMO patients. I would say the survival of ECMO patients is almost more than 70%. And these are very many success stories are there. These are the patient who was on ECMO for 27 days, on ventilation for 55 days, but she went home alive. And yes, these things can happen only when we have periodic drills and periodic resuscitation, including drills for maternal cardiac arrest. This was the guidelines that I was talking about. I was the leader of the task force committee of AOA, and we brought out these guidelines in 2020. From the 12 very mortem deaths that we had, around 58% survival. And of course, everybody contributed, but the data was all ours. So the thing is, once you achieve ROSC following maternal cardiac arrest, it is important that you prevent rearrest. Again, this was the data that came from our guidelines. I would say it has come in the recent AHA guidelines. But importantly, when you have a mother with maternal cardiac arrest, you revive it. You do a perimortem cesarean delivery, you can achieve ROSC. But again, 70% of women who achieve ROSC, they have atonic PPH, because it could be either sepsis as the cause of maternal cardiac arrest, or hemorrhage atonic PPH cause of maternal cardiac arrest. And there is atonic PPH. Again, if you give oxytocin as a bolus or as a rapid bolus, the rearrest rate is very high. So make sure that oxytocics have to be used judiciously in a patient post ROSC, and this point has come from our guidelines, which we have emphasized. And you need to make sure that instead of oxytocin or oxytocics, you can use surgical methods like compression sutures, Chose sutures, or Beeline sutures, rather than pharmacological management. And vascular clamps. In case of major hemorrhage, again, this data has come from our hospital. Aortic clamp or Reboa balloon, or you can use common iliac vascular clamps, because uncontrolled hemorrhage, you just have to do a manual compression of aorta, or you can use any of these vascular clamps to arrest the hemorrhage. Again, clamping the aorta infrarenally is a skill that requires a very short learning curve, and every surgeon has to be well versed with these skills, because they are life-saving skills. This was again data from Dr. Piley and our own. This was a couple that survived following maternal cardiac arrest, and we have many such good stories. So the lesson that we have learned from critical care or overall prevention of maternal death is eternal vigilance. Again, you will be caught unaware. You need to have drills, protocolize the drills, because these events are less frequent, and you do not register if you don't drill properly. And at our place, we do this OELSS, Obstetric Emergency Life Support Skills. We teach the obstetricians our skills, and obstetrician teaches us their skills of like helper algorithm for shoulder dystocia or any of those things. So basically, it's a team effort, and obstetric is one specialty where symbiotic relationship is very important. They depend on us, we depend on them, and end of the day, we both take care of the patients for their better survival, because no mother should die. This is another perimortem cesarean delivery. The mother didn't want her to be picked, but you can see the chubby baby survived, the mother survived. And point of care ultrasound, again, this is one thing that we all have to be well versed. So lastly, I'll just end up with this case. This is the case that taught us to think laterally, because many a times the moment the surgeon says emergency cesarean section, our discussion is, should I give spinal, should I give epidural, should I give combined spinal epidural, or should I give GA? Beyond that, we don't think. So this was a patient who booked, this was a booked case, mild preeclampsia, but she had severe headache. She came to ICU with severe headache, unbearable headache, and the obstetrician said, sir, cesarean section karna hai, she has imminent eclampsia. GCS was 15, pupils were normal in size, reacting to light. And when I examined the patient, she was having sixth nerve palsy. So we said, let me, because it was a categorization of section was important. So when we categorize a section, the CST was reactive, NST was reactive. We sent her for CT brain. And when the patient was sent for CT brain, again, Fernandez Hospital doesn't have a CT or MRI. We sent to nearby hospital, Apollo Hyderabad. And this is what we found. I don't know how many of you can relate, but this was a bullet in the brain. She was shot by her husband through the nostril, and the family, the in-laws said they wanted her to die during surgery, during anesthesia. Fortunately, she came to us, she survived. We did a cesarean section and we did craniotomy, extracted the subdural and extradural hemorrhage, and she survived. Of course, she developed CSF rhinorrhea that was tackled. But point which I want to say is, always categorize the cesarean section. So when you have when you have an atypical presentation and there is no time, if it's a category 1 section, and if you have to give GA, do not extubate this woman. Because if you extubate this woman and if the woman has a delayed recovery, the anesthetic cause or anesthesia is blamed that is because of anesthesia cause the patient has not recovered well. Invariably, it is something else. So whenever you give GA to a hypertensive parturient, assess the patient before extubation, and if you feel that patient is not behaving the way she has to behave, have a low threshold to do radio imaging, either MRI of the brain with MR venogram, because you can pick up Press syndrome, you can pick up cerebral stenosis, sometimes cerebral bleed also. Of course, this patient recovered completely. She had sixth nerve palsy, which remained for a long time, but we could salvage the potential divorce also later on. The point which I want to convey is, always have an ability to think laterally. So again, anesthesiologists can make a fantastic dent and significant dent in terms of preventing a near miss and preventing maternal morbidity and mortality. And if you see the data over the years, the anesthesia as a cause of maternal death has been reducing significantly. And this has happened because of regular audit. And we have this dashboard audit. My colleague, one of our fellow, presented this dashboard audit in SOAP conference in the US 2011, which won the best paper award. Again, this has been published in IGI journal also. So the success story is the death at the start. If you look at 1960s data, anesthesia was one of the third common cause of maternal death. Now it's the least common cause of maternal death. And this has happened only because we have moved to regional, we have done more audits, we do more audits, and we work as a team. We know the cause why the mothers die, and we are making a difference in the maternal survival rate, significant difference. So to conclude, I would say that we need to have a protocolized approach in the factors that sepsis, hypertension, hemorrhage, cardiac causes, and anaphylaxis and embolism. Regional is by far safer than GA, but see that you make the regional safe, you make the GA safe, and it is up to us. Have airway plan management plan with capnography mandatory, heavy laryngoscope mandatory, planned extubation. Extubation is elective, it's not emergency, and it's very, very important. Sepsis, hit hard, hit fast. Avoid high spinals, total spinals. If at all, use adrenaline early rather than late. And if you have a high risk patient, transfer them early to higher center and make sure that you stabilize the patient and monitor them in ICU for longer time. Multidisciplinary team approach and constituting a MDT is very, very important, and audits are very, very important. The audits every 4 to 6 months, you need to have drills in difficult airway, high spinal, total spinal, last, eclampsia, hemorrhage, and mental cardiac arrest. Unless you do the drills, you cannot progress. So to conclude, I would say that turn deaths into near misses and turn near misses into the mothers who go home well. This is the book that I published just last week. It is a compendium on maternal critical care. And as I said, this is the acronym that has been devised by us. So every she deserves to go home. With this, I conclude, and I thank you very much again, ISA Vizag, for giving me this opportunity to be with you. And almost have taken almost an hour or so, so we can take the questions. Thank you so much again, Dr. Bhuvaneshwar, Bhimeshwar sir, and uh, Kurmanath Garu, and Venugopal, and the entire ISA Vizag team.
Thank you, Sunil. A wonderful presentation as usual. The take-home points for the sake of postgraduates is the eternal vigilance, anticipation, preparedness, timely help, either from the colleague or the good technicians. Of course, blood bank, skills development, drill, and audit as well as. So I will see the chat box for any questions there. Right now there are no questions, but from my side, Dr. Sunil, you suggested the phenylephrine is the prophylactic phenylephrine. Do you suggest phenylephrine irrespective of the heart rate, or do you suggest any heart rate? Because we do get bradycardia 40, 45, 50. That is the first thing.
So generally what we do is, before the bradycardia sets in, give phenylephrine. So do not wait for the heart rate to drop, do not wait for the hypotension to occur. So what we do is we just give about 50 mg phenylephrine, or 100 mg of phenylephrine is added in the co-load.
Okay.
So that it just goes as a rapid infusion. And if at all, yes, if you have missed that period and the patient's bradycardia, then F15 is the drug of choice, not phenylephrine. But you just have to make sure that before hypotension happens, tachycardia is the earliest sign of spinal hypertension. So when you see tachycardia, just give a bolus, because after that patient is going to have brady and hypotension. So initial sign of post-spinal hypotension is initial tachycardia. So when the mother has tachycardia, just push about 50 mg of 20 to 30 mg of phenylephrine, or 50 mg of phenylephrine, and you can avoid hypotension, because 5 to 7 years of hypertension is not going to cause anything. But if the baby is distressed, fetal distress, or pathological CTs, then it can make a dent, because the blood delivery to the fetus can be jeopardized. So phenylephrine is a drug of choice. But yes, if you miss that window of and bradycardia has happened, then you can switch to ephedrine.
Yeah, thank you, Sunil. There is an comparative study between the phenylephrine and the noradrenaline infusion also quite few years back also.
Yeah, see, NORAD also is, if you ask me, most of the data currently, noradrenaline is the vasopressor of choice. But diluting noradrenaline and making an infusion and giving 50 to 100 mg of noradrenaline is a little cumbersome, and it takes a protocolized approach, because we have to make a syringe infuser and all those things. So if you can do that, nothing like it. Noradrenaline is a drug of choice, because it does not affect the cardiac output. Whereas phenylephrine, it maintains the pH in the neonate or the newborn, but whenever there is bradycardia, the maternal cardiac output can fall. So compared to this, noradrenaline is superior in that aspect.
Okay, Sunil. Thank you very much. I expected you will share some experience about the airway changes in pregnancy, and the second one is the tab block from you. If you just for the sake of just
So
one line.
again, as I said, I just mentioned briefly, because airway, yes, I just mentioned the incidence of difficult airway. Pregnant women are 10 times more difficult airway than in non-pregnant women. And because of the changes, because of the low oncotic pressure, If you look at the serum albumin level in pregnancy is reduced, the oncotic pressure is reduced, the ability of albumin to bind fluids in the intravascular compartment is reduced. So the fluid escapes to the third space very, very easily. And hence they developed engorged mucosa in the nasal cavity, in the oropharynx, the tongue, the pharynx, the larynx, the false vocal cords, the tracheal lumen also is reduced. The mammaries are enlarged. The diaphragm is pushed up. The lower esophageal tone is reduced. The upper esophageal sphincter also is relaxed. The risk of aspiration is more increased, and the gastric emptying time is prolonged. And all these things, and importantly, the oxygen consumption is increased by almost 200 to 500% if the mother is in labor. So one side you have increased oxygen consumption, other side you have difficult airway, and they have a tendency to go into hypoxemia very, very rapidly. At the tidal expiration, the closing volume and the closing, happens. The effort is reduced. So all these things make intubations more difficult, hypoxia very early. Hence, the uh, protocol for maintaining peri-intubation normoxemia is very important. So you can maintain normoxemia by improvising the techniques of pre-oxygenation. So conventionally, we have been taught that pre-oxygenation for 5 minutes, 3 minutes to 5 minutes is good enough, or 8 vital capacity breaths. But current standards are go for HFNC. I just briefly mentioned the photograph. I showed HFNC, high flow nasal cannula or high flow nasal oxygenation. That should be the norm. Or you use CPAP with pressure support as a pre-oxygenation tool. Or if the mother is in state of shock, you can use ketamine and use delayed sequence intubation as a pre-oxygenation tool. So there are several methods of using or improving apneic oxygenation or peri-intubation oxygenation to the mother, and you can avoid hypoxemia at the intubation because airway is going to be difficult. And once you intubate this patient, the job doesn't get over. Make sure that
Yes,
extubation
sir.
is planned
Yes.
because especially hypertensive disorders, the control of blood pressure during laryngoscopy and during extubation is very important because if the pressures are uncontrolled during intubation, extubation, it can lead to intracerebral bleeds and hemorrhage, and we all know that. So, laryngosympathetic response, use of
Yes, sir.
appropriate vasodilators, NTGs, or labetalol, or magnesium, or fentanyl,
Yes.
or ibipentanyl, dexmedetomidine, multiple drugs are there. You need to use them. I didn't elaborate because I just wanted to give an overview of.
Yes, sir. Yes.
Yeah.
Thank you. Thank you. With your permission, let me add one thing. Airway changes in pregnancy. In the first trimester, it may be the Malampati grade 1. It goes to the Malampati 3 or 4 in the 37, 38 weeks also.
Yeah.
With this, I thank Dr. Sunil Pandya, an excellent presentation. Very, very useful to the practitioners as well as the postgraduates. Thank you, Bimesh. Thank you, Kornad, and Dr. Thank you,
I have one
ISO
question,
Visakhapatnam.
Dr. Pandya.
Yeah.
I have one question, Dr. Pandya.
Tell me, sir.
Uh, so thank you very much for your elaborative and extensive talk and for sharing your vast experiences. Actually, nowadays I'm observing the incidence of perioperative cardiomyopathy in post-cesarean cases we are finding.
Yes, sir.
Usually we don't do 2D echo as usual for a young lady, but after that they are developing hypokinesia and getting admitted into the ICU. What is your experience, sir?
So as I said earlier, most of the cardiac elements are picked up during delivery or postpartum. So currently, the international guidelines does not recommend echo in all the women before delivery. But again, I am one of the lead, I would say, task force lead for Cardio Obstetric Society guidelines in pregnancy. We are developing guidelines for various ailments, and Dr. Justin Paul is leading this. He's a cardiologist, obstetric cardiologist, and at least in Tamil Nadu, they have introduced mandatory echo in last trimester before delivery. That is universal in Tamil Nadu.
For
Uh,
all cases?
all pregnant women should have
All.
echo before delivery in the third trimester. It's a good thing, I would say, because as I said, these occult heart diseases like peripartum cardiomyopathies, mitral stenosis, and stenotic lesions who remain asymptomatic because of the increased physiological changes in pregnancy. they become symptomatic during delivery, during oxytocin, during multiple insults that can happen in the peripartum period. So, if you ask me, uh, echo should be mandatory for all pregnant women. But again, if you make a guideline and if you make it mandatory, then availability of cardiologists in all the countries or all the states or districts across peripheries can become difficult, can become challenging. So it's not come in the national guidelines, but Tamil Nadu, they have made an effort to make it mandatory across the entire state of Tamil Nadu.
But
Hopefully,
options are not allowing us to ask for 2D echo, sir. That's the main problem.
at least when you have the facility like Visakhapatnam or any of those developed cities, it should be mandatory, if you ask me. Yes.
Thank you, sir. Thank you.
Again, picking up the subtle signs are very important. First, unexplained tachycardia, unexplained dyspnea on exertion, progressively increasing dyspnea, fatigue, unexplained fatigue. So, but again, as I said, all these things are confusing because most of the pregnant women, they have the symptoms. So you just have to have an eye to pick up those, what is physiological and what is pathological.
Okay.
Yes, sir.
Thank you, sir. Thank you.
Thank you.
Yes.
Right, sir. Thank you,
Yes,
Sunil.
sir.
A wonderful presentation.
Thank you, sir.
And I now hand over to the Secretary, Dr. Praveen.
Hi, Sunil Pandya. I'm Chakra here.
Sir, Chakra, sir, good evening.
Sir,
How are
good
you?
evening, sir. Sir, good evening, sir. Good evening, sir.
Are
Good
back.
evening, sir.
We are in, we, we are in the
Dr.
election
Anuradha.
favor.
Sir, good evening, sir. Chakra sir.
Good evening, good evening.
Good evening,
Anuradha,
sir.
sir.
Good evening, good evening.
Chakra garu, good evening.
Good evening, good evening. ఇప్పుడే
Sir.
ఎలక్షన్ గొడవ అయింది గొడవ లేదు కదా ఎలక్షన్ ఆ హీట్ ఉన్నాం కానీ
Result bound, sir.
బాగుంది బాగుందంటే అదే మన క్యాండిడేట్ అయితే బాగుంది అనుకుంటాం లేకపోతే దొంగలని చెప్పాను
Sir, my heartfelt thank you for Dr. Sunil, sir, for your outstanding presentation and on obstetric critical care. Your expertise and passion for teaching made the session both memorable and impactful. So today I learned about the 3 habits and 6 places, sir.
Thank you, madam.
Thank you so much for moderators today, Dr. M.V. Bhimeshwar sir and Venkata Venugopal sir and Kormanath sir. So insightful comments, effective facilitation, enriched the discussion and enhanced our learning experience. We are truly grateful for your valuable contributions, sir. Thank you so much, sir.